Ultrasound is a dialogical examination. That means we had the chance to communicate to each other, and I asked the patient some questions. For example, why he has such a large scar on his abdomen, and he told me that 12 years ago he was operated for an colonic cancer, and he at the same time was diagnosed with an chronic hepatitis, was treated, but liver cirrhosis developed in his patient. And the third problem he mentioned was that he is a diabetic. But he has no acute pain, but feels a little bit tired in the last weeks, is not as good as he wished to be, and therefore now we perform an ultrasound examination. And let me say that never start with a point of pain. Then it could be that the examination lasts only a few seconds because the patient will not cooperate if you cause pain. And the second thing I would say in advance, please always follow a systematic approach. Because if you concentrate, for example, patient says he has a right upper quadrant pain, and you go to the gallbladder, find stones, and you love these stones, and you document these stones and make 5 films and 6 images, but you forgot to look to the left kidney, and there was a tumor. Yeah? And this shouldn't appear, and therefore follow a systematic approach. Now we have an advanced ultrasound machine. We have a patient which is a little bit obese, and I every time start with a longitudinal section in the median line, and in this situation you always will see first the liver, the left liver lobe, and if you are lucky you can see the large vessels. And please take a deep breath. Einatmen bitte. Und die Luft anhalten. It not always helps, but in this case the liver comes down to the transducer, and you can see a bright liver, a hyperechoic liver. Of course you can breathe. You see only a few vessels. Please take again a deep breath. Yeah. If you are looking for how we can find, I need use the caliper. Here is the left liver vein. It is small. You can't see it in the periphery. That seems like a fatty liver, but you have no comparison in this situation. But in the left liver lobe, you don't see any focal lesion, for example. The second you can see in this image is a transverse section of the stomach. You see very well this dark line. This dark line, this hypoechoic structure, is a deep muscle layer of the stomach, and you see content within the stomach which causes some shadows and some reverberation. Please take again a deep breath. Einatmen. Ja, okay. Und wieder ausatmen. I have to take a little bit pressure with the probe to see the vessels, because the vessels are in this case relatively deep. What you can see here are the superior mesenteric vessels. Okay, nicht so gegenpressen, sondern flach atmen und entspannt sein. And here we see the superior mesenteric vein. But we don't see very well the aorta. Here we can see a little bit of the aorta, which is important, I think. Wie alt sind Sie? How old are you? Wie alt sind Sie? 70 Jahre. 70 years, that means this is an age you have a higher prevalence of aortic aneurysm. Therefore, in screening, of course, always look to the aorta, but this has a normal side. So of course, you have to add the transverse section. And now I try the transverse section and einatmen. Yeah. Now we again see the left liver lobe. We see the portal vein. And I tried to get an image of the pancreas. Schön locker lassen den Bauch. Ja. I said not pressure. I have to go a little bit deeper. And now we see a little bit of the pancreas. It is not very good, but we see here parts of the pancreatic head and pancreatic body, which is hyperechoic. If I turn a little bit the transducer to the left shoulder, I have a better chance to see also parts of the left pancreas. Now we succeed. Not very well imaged, but you can see it is a hyperechoic pancreas, which very well relates to his history of diabetes mellitus. Pancreatic lipomatosis, that means fatty disease of the pancreas, is first seen in patients with metabolic syndrome and diabetes mellitus before they develop liver steatosis in most cases. Second, we don't see any dilatation of the main pancreatic duct, and that has a high, very high negative predictive value for pancreatic head cancer, because it is very rare occurrence that the pancreatic head cancer occurs without dilatation of the main pancreatic duct. Why this is important? He is at risk, a higher risk to have a pancreatic cancer than a person of his age without diabetes mellitus. The risk is twofold compared to the normal non-diabetic population. And what you see in this case, if you insist, that means slight pressure, and ask the patient not to press against. Younger men often press against. They have muscles in their abdomen and they will show them. But if you discuss that with the patient, he will be relaxed. And now we have this 1 minute or 2 minutes nearly good image of the pancreas. Here with the portal confluence and with the splenic vein, and here we have a little bit of the superior mesenteric artery, and here behind of the aorta. Then I go down to look for the aorta. I cannot always see the whole aorta, but now we reach a bifurcation and there is no aortic aneurysm. This is for sure. Then in my personal algorithm, I go to the left flank and look first for the spleen. Here we have the spleen. Ein bisschen einatmen. Okay. Here we see the upper pole, the lower pole and the hilum of the spleen. Und nochmal ein wenig einatmen. Stop. Here we see part of the pancreatic tail. This is this hyperechoic area. Here's the stomach with air, and here we see the pancreatic tail. Okay. 1/3 of the pancreas will not be seen in obese patients and normal patients from the transverse section. We don't know exactly if 10% or 30 or 35%. In very thin patients, you can have the whole pancreas from the transverse section, but always add this opportunity to the pancreatic tail through the window of the spleen. Not always possible, but very, very helpful. And then I go maybe 5 centimeters down and a little bit back, because the kidney is a retroperitoneal organ, of course. And therefore, don't try to look to the left kidney from this position. Sometimes it will work, but in most cases there's air in between and then you will not see the left kidney. Please take a deep breath. Einatmen, tief. Yeah. Now you can see the left kidney in a longitudinal section. Okay. He has a history of diabetes. The kidney is one of the affected organs, but we don't see any pathology of the kidney. It has a normal parenchymal relation to the central echogenic reflex. Noch einmal tief einatmen. There's no dilatation of the pelvis. There's a smooth contour of the organ. There's no pathology, no focal lesion, no cyst. In 70 years old people, I think 70% of persons have kidney cyst, but he don't have. But he can be happy of that. But we have not the time, I think, to do it. if you want to see if there's any damage of microcirculation of the left or of the right kidney, we can use the Doppler and to make a pulse wave Doppler and calculate the resistive index. It should be around 0.7, 0.75. This is normal. If it is higher, for example, 0.8, 0.9, this is an expression of an increased intrarenal arterial resistance because of microvascular damage in kidney disease, in diabetic kidney disease. I can demonstrate it. We have, of course, to adjust the Doppler. There's too much noise. Therefore, there's a scale. Yeah, we have the pulse repetition frequency too. Okay, it will work. Yes, you have to adjust, but I don't find the right. Here the scale is too low. Here's scale. Okay. Okay. Please take a deep breath. Und jetzt mal nicht atmen. Kleinen Moment. Yeah, it is not easy for him. Okay, this is enough because we have two good signals. It is not for a book to be published. It is for practical reasons. They are both same and therefore we can use it for calculation. Manual trace because I rely on my own set and also okay, yeah. It does not matter because we only use these two values, this peak systolic velocity and the end diastolic velocity, and the machine calculated a resistive index of 0.79. That means it is slightly elevated. And he has a history. Wie viele Jahre Diabetes? Wie viele Jahre haben Sie Diabetes, Zuckerkrankheit? Yeah, also 15 years, and he says that he is hyperglycemic over a long period, but it has not caused a very severe diabetic nephropathy because then the end diastolic velocity would be lower because of high intrarenal arterial resistance, and 0.79 is moderately elevated. That means he will. Yeah. He has only tablets for his diabetes. Okay. Then, of course, we have to go to the colon and so, but I tried to do it as in the last phase of my examination. I go back to B mode, look for the bladder and to the prostate. Here we see a filled not gallbladder, but bladder, urinary bladder, without any solid contents, without any mural nodule also, and we see nearly normal appearing prostate. You can calculate the volume, of course, but I think it is not necessary now. There's no obvious pathology, but remember, prostate cancer is not an ultrasound diagnosis. This is a diagnosis of palpation plus, but do it before blood examination, PSA, and in most cases you will not see small prostate cancer. Only very large cancers going beyond the organ will be diagnosed. The most large and inhomogeneous prostates are only hyperplasia with some calcifications and regressive changes due to age of the patient. Okay, then I go to the right upper quadrant, der rechte Oberbauch. Ja, alles in Ordnung. And you see that if we have this position of the transducer, directed to the right shoulder, we don't see so much from the right liver lobe. The patient needs to help us, or we need to give him another possibility of another position. But first we try that he helps us. Tief einatmen. Yeah, now it looks a little bit better because the liver comes down and we see a little bit from the gallbladder, but this is not a very good image and we can't really decide if there may be a small stone in the infundibulum. Therefore, in this situation, I would ask the patient to turn to the left side, einmal auf die linke Seite drehen. In my hospital, the young doctors don't do that. But it belongs to each ultrasound examination of the abdomen, only if it is not possible because you have a 90-year-old lady which has severe pain in the spine also. But always, if possible, turn the patient to the left lateral position. And the reason for that recommendation you will see. Tief einatmen. Now we have a much better, not very good, but much better image of the gallbladder. And we see, ja, okay, nochmal tief einatmen. Ja, ja, nicht. And we see much more of the left liver lobe. Is there anybody in the room who has an impression of a pathological finding? I had. Yeah, I guess there's an hypoechoic lesion. I don't know if there has been done an ultrasound examination before, but of course we have to tell that to the patient after the examination and recommend further imaging, for example, this contrast-enhanced ultrasound. This is located in the section, in the fourth segment of the liver and has a diameter of 24 millimeters. Okay. And noch einmal tief einatmen. Yeah. I look for the other segments of the liver. As already said, with regard to the left liver lobe, we don't see much vessels. The diameter of the splenic of the liver veins is diminished, and of course we see attenuation. We have to correct in this case our focus position and have to go down. I'm not familiar with this machine. Focus, here's the focus. I go down, and in most machines you have the choice to go, for example, to a deep penetration modus. Would help us in this case. Do you have? Yeah, okay. We have to go down with a, yeah. Okay, may be helpful. We try. Tief einatmen noch einmal. Now we have a little bit better penetration through the liver. It is not easy for him. I feel that it doesn't improve. Okay, we go back. Yeah, we go back and we only reduce a little bit the frequency. Yeah. Okay. Noch einmal tief einatmen. Yeah. Okay, I think this is the optimum now. He presses against my transducer. Tut das weh? Nicht, ja, weil sie sehr stark gegenpressen. Okay. If we have difficulties and we have a little bit to see the whole liver from this position, then we use the intercostal space. We are not able to see the whole liver from the intercostal space, but it helps us to visualize most parts of the right liver lobe. And now we see very well the middle liver vein. Ein bisschen einatmen. Stop. Yeah. I make a still image, and you see that this is liver vein, this is not portal vein. And normally the liver vein has no echogenic outline. This has, and there are some irregularities in the contour of the liver vein. Not very severe, but they are we can visualize them. And this is the inner surface of the liver. Because he has only a few amount of ascites, maybe 1 millimeter or so, we are not able to have a good impression of the outer surface of the liver. But this is fluid, blood within the liver vein, and we have a good chance to see irregularities of the nodularity of the liver with regard to the outline of the liver vein. Second, we can perform Doppler of the liver veins. It is not very important when we diagnose liver cirrhosis, for example, but it is important, for example, if we look for right heart failure, then we can see changes in the flow. In liver disease, you have a broad spectrum of liver vein flow. In some cases of severe steatosis and steatocirrhosis, we have a diminished phasic flow in the liver veins. And in this position, we can also perform an Doppler imaging of the portal vein, which is important in case of liver cirrhosis. And he said us that we can make a simple measurement. I think Paul Situ mentioned that in his presentation. Nicht atmen. So bleiben. Okay. Weiteratmen. We could optimize, but it's enough, I think. We have to adapt the angle, here we have, to the direction of the vessel. In this case, we have 32 degrees correction. That is not so much, and there will be no so much change in the measurement of the velocity. And we have a velocity of 16 centimeters per second. Normal would be around 20 centimeters per second. This is a little bit slow, but it is not very slow and allows not the diagnosis of portal hypertension. It is only a hint in the direction of possible portal hypertension. We could also use all these tools we don't have in family practice office, normally the elastography and attenuation imaging. I will not do that, but I will show you that if you follow the left liver vein, you see all these irregularities of the liver vein, and this is a clear sign that there should be really a liver cirrhosis. We don't see the outer surface, but we see the inner surface of the liver, and we see a nodule. We can see it also from this position, and I had the choice to perform contrast-enhanced ultrasound, I would perform that, and I would perform that in this situation, because the patient doesn't need to have a deep inspiration to visualize in this position, and therefore we had a good position to characterize this lesion. But we have to remember that if we found in a patient with a long history of liver cirrhosis, there is an 85% probability that this should be HCC. Yeah? There are differential diagnoses, but they are rare. We can perform in this situation color-coded imaging, but in most cases it will not help us. Has this machine any kind of microvascular imaging? Yeah, okay, then we try that. Bitte Luft anhalten. Nee, nicht einatmen, ausatmen und anhalten. Ja, atmen Sie mal weiter. Und jetzt Stopp. Ja, we had to adjust. I don't know. I'm not so familiar with this machine. Ah, yes. Now, okay, weiteratmen. This is only a slight impression. We see here one vessel going inside, and maybe that there are some in the periphery. I think it would work better if I had any experience with this machine and if we better adjust. This microvascular imaging is very helpful, and many vendors have included it in their machines. First, it was introduced by Canon, formerly Toshiba, and has there a very high quality, but I'm not familiar. Maybe that we can adjust it, that we see the small vessels which are irregular in case of HCC. HCC is a hypervascular lesion, and with contrast enhanced ultrasound we would expect to have in the arterial fast chaotic vessels and fast and high enhancement of the lesion compared to the surrounding parenchyma. We wait for 2 minutes, for 3 minutes, and nothing will occur. But maybe that in the region of 2, 3, or 4 minutes, then enhancement goes down. That means we have a washout of the lesion, but it is late in most cases of HCC, and it is slow in most cases of HCC. Only in non-differentiated, very aggressive HCC, we have a fast hypoenhancement. Yeah.
How can you differentiate the regenerated nodules from the cirrhotic liver?
Yeah, it is difficult, but they don't show any, and they have vascularization, and they are hypervascular or sometimes a little bit hypervascular, but they don't show any hypoenhancement, no washout. But yeah, in this case, you have to use COS, or you send the patient not to CT, but rather to MR imaging, because MRI is the, I think the reference standard, but if you have good visualization, contrast enhanced ultrasound is as good. We have a classification system from the United States, which is internationally accepted, the Lee-Rutz classification, liver radiology reporting system, and this exists for MRI, this exists for CT, and this exists for contrast enhanced ultrasound. And you can say, because of the enhancement pattern and the occurrence of washout and the time of washout, if this is a rather benign diagnosis, a rather malignant, and how high is the chance that this is HCC. There's a classification from Lee-Rutz 1 to Lee-Rutz 5, and don't know in this case because we have not performed choice. Yeah. Okay, now I leave the liver. Ja. Wir sind gleich fertig. Ja. So, dann kommt noch die rechte Niere, the right kidney now. Yeah, it looks like the left kidney. Of course, you have ever to perform a transverse section. You can measure, but it is not necessary in this case because it is around 10 to 11 centimeters, and therefore we don't need that. And what is in most cases not so easy is, in this case will be a little bit difficult to look for the porta hepatis to the common bile duct, but we should try, of course, to do that. We can do that in very difficult situations from this position, from an intercostal route. Here you see the portal vein, and you don't see any dilated tubular structure in front of the portal vein. That means that a significant dilatation of the common bile duct is not visible and is nearly excluded. But I don't see now clearly where the common bile duct is. Second position is the shoulder umbilicus position of the transducer. Jetzt müssen Sie noch einmal helfen durch tiefes Einatmen. Ja, he helps us. Ja, jetzt sehen, now we see the course of the portal, okay, the course of the portal vein coming down there, but maybe that this is a common bile duct, but I didn't see it exactly. But what we can say, there's no dilatation. If the question is if there's a stone inside, we can say not possible in this patient, in this situation, to say that, because in a normal size, normal diameter common bile duct, there could be, of course, a 2 mm or 5 mm stone, but he has no stones in the gallbladder, and therefore it is not very important, I think, to clarify this question now. Okay. Yes, are there any questions? Shall I show something more?
Can I ask you? So some hypoechoic lesions.
Yeah,
Do
one.
you think that they are satellites? The satellite lesions from
Yeah,
around the bigger ones.
yeah. Where you see these satellite lesions or possible satellites? I think this is a little bit speculation. I only see this lesion of 2.5 centimeters, and this, for example, is not a second lesion. I think you will need MRI or you need a contrast enhanced imaging tool to see small, maybe 5-6 millimeter satellite lesions. We don't see any in this case, I think. Yeah. What we can do is to perform an Doppler examination of the middle liver vein. Here we have. You see nearly no variation in flow velocity. Normally, we would see a variation. We would see a very short red phase. That means flow back from the heart, and we don't see that. Nicht atmen. Ja, okay. Weiteratmen. Every time in relaxed position, not in deep inspiration, because then you flatten artificially the liver vein phasic profile. And here we see a situation with only a little bit flow velocity variation. That means it is diminished. There's no phasicity or only a little bit phasicity. And this means that there's a diseased liver. No more. There's a stiffer liver, and therefore it is damping of the phasicity of the liver vein flow. This is a secondary sign, not for liver cirrhosis, but more for liver steatosis and for diseased liver in general. But we did know that from history of the patient. Okay. Yeah. What we should do in addition? Okay. What forgotten? We have something forgotten. We have forgotten the talk of Professor Sporia to look for the gastrointestinal tube. We shall do that. Come back to the back, also auf den Rücken zurück. Ja, come back. Yeah. We have already seen the stomach. I think you will remember. Okay. The stomach, the antrum, and the lower body of the stomach is between the left liver lobe and the pancreas. And here we have it now in a longitudinal, as a transverse section of the body, but in a longitudinal section of the lower part of the stomach. What you see with this transducer, of course, we can change the transducer to a high frequency transducer to have a better image, is that there is a layering of the gastric wall, and we see exactly this very hypoechoic layer. This is a deep muscle layer. We see it twice because we see it in the ventral part, and we see it on the dorsal part of the gastric antrum. We see here a hyperechoic, sorry, I was wrong. We see two hypoechoic layers, this one, and on the back we don't see two, we see only one. And this is a mucosa. This is a submucosa, this hyperechoic, and this hypoechoic is a muscle layer. Here we see the pylorus. Bisschen einatmen. Stop. Here's the pylorus, and if we had a fluid inside the stomach, we would see sometimes the passage of some fluids, okay, to the duodenal bulb. Here is the duodenal bulb. We don't see it really, but we see the air in the upper parts of the duodenal bulb, and the pyloric region is here, but we don't see it because there's no movement in the moment. Yeah? We can say that there's no thickening of the gastric wall. It could be maybe 5 or 6 millimeters. Here we have what we have 5.8 millimeters. This is completely normal, and we don't see the complete stomach in this case, only the lower parts. Now we see very much better the pancreas. This is a lesson to be learned. If you had not a very good image from the pancreas in the first minutes of the examination, at the end of the examination, come back to the pancreas, you have a second chance and use this second chance. We have to optimize the focus. Now we can see easily the pancreas, which has a high attenuation. That means there is darkening below the pancreas because it is a fatty pancreas, but this is the only visible pathology. You may not see the whole pancreatic head because there is some blurring because of lipomatosis. Okay, then you can look to the colon. This is easy to be found because there's a lot of air and stool within, and you have, if you use the longitudinal section, you can see the horse tray. Yeah? Here's haustration of the left colon. You don't see really the wall with stratification like in the stomach. Then you need a higher frequency transducer, but you can see this haustration, and you can go also in the transverse section, and sometimes you can see here the muscle layer. This is this black one, and here you see the haustration very good. And if the patient had pain in this region, look in the surrounding, look for diverticula. I don't see here any diverticula. Maybe that he have, but I don't see any. And of course, I don't see any sign of diverticulitis. We don't see any fluid here. And you, of course, can also follow the right colon down. It is not so easy to find. Here it is. A lot of air. Yeah, but not very good delineation. And of course, we have no chance in this patient, in this situation, to find the normal appendix. And maybe that it has been removed in connection with this colonic surgery. But I think in this case, you will not have a very good chance to find it. Okay. Do you want to try by yourself? Ja. Ja, wenn Sie nicht mehr können, bitte sagen. Ja, natürlich.
breast for the patient, not the right one. Because I am going to ask her to move, and I want that she look at the screen. She not model. What her name? Dana. So I make the examination of Dana, not of breast. So she is going to be in oblique position, and I am going to explain her here. If she understand, the job is good done. Because if you understand, she will understand. And if she understands, she will be confident with me, and she will believe my exam. So, tack, and here, now, and the end here. You see the screen here? Okay, it's okay. So, have you any comments to my picture? Remember, we freeze is here. On the presentation, we permanently show you that the nipple should be there, and to automatically see this in good position. So you see that the nipple is here. So for me, it's impossible to make a good examination if you have not the good probe positioning. Less gain. Arrow, pointer. Here you have the nipple, here, the areola, and the skin. And then under you have here you have the lobe. You see some ductal axis there, following the lobe. I press again or for the... Okay. Oh, okay, that will be good like that. So we are here from the nipple to the extremity. Here you have the chest wall, pointer. You have the chest wall, and here from there to here, you have the hyperechogenic structure of the lobe itself. At the upper part, you have the fatty environment, the superficial fatty tissue, and some Cooper ligaments, but I will show better the Cooper ligaments. In the lobe, you have some ductal axis. They are not straight, they are a little tortuous. So for that, I am going to press a little bit, just to press a little bit, and to see that you have a long duct axis. You see one Cooper ligament going there, another one here, and here you have another Cooper ligament going toward the extremity. Why it's important to follow the Cooper ligament? Because if you have some pathology one day, the pathology will follow the duct and you will see the indirect sign here, not there. because they are going to follow the Cooper ligament orientation. So upper part of the lobe, lower part of the lobe, lower Cooper ligaments here, another one, and here it's a complex image, but you have here hypoechogenic structure. So we just have a look to this hypoechogenic structure. Zoom. You see the black ductal axis, then it's very difficult. It's not easy to see that. Have a look. You have here a part of a ductal axis. You see that going toward the nipple. From here, you have some ductule 1, 2, 3 perpendicular, and you have here some group of lobule 1, 2, 3, 4. You see that or not? So I am going to maybe change the gain, because you have thousands of small structures like that. Have a look here. You see like trees on the roadside. You see then ductule lobule. Ductule lobule, a group of lobule here, another one, another one, another one. You have a lot. Remember the video with all these terminoductolobular units. But maybe it's complex. We start again with the normal anatomy. The nipple is here. Here is the skin, the chest wall, and you agree with me that the lobe structure, longitudinal lobar, from here to there. That's a hyperechogenic lobule. In the lobule, you have some ductal axes. They are very small one, black, and here you have a Cooper ligaments oriented toward the extremity of the lobe, and you have here the extremity of the lobe. So I go from the extremity, you see in black the duct, and I go now toward the nipple. You follow the lobe. You see the Cooper ligament superior, inferior, and then I go to the nipple area. Nearby the nipple, you have a concentration of ducts, because all the ducts are converging to go to the nipple, and you have 1, 2, 3, 4, 5 ducts. You have a small dilatation, physiological one, behind the areola. So you have the areola, you have the lobe. In the lobe, you have some ductal hypoechogenic black structure, and then the lobe going here with the Cooper ligament. You are able to see that or not? So now we are here and we go toward the extremity, strictly perpendicular to the skin. I do not press except if I want to make some seismoechography to move. And you see that the ducts are little curved, so I have to press or little bit oblique to follow them. You see how many small ducts we are looking for? And then here you have the extremity of the lobe, inferior part, and you have here the beginning of the involution of the breast. The breast is after the menopause is going to disappear completely, and you have fatty infiltration coming from external part toward the nipple, and you have here fatty involution, and this duct axis is going to disappear completely in few months or few years, and so you have only this residual part in the evolution. You see, just move a little bit to show you the ductal axis. Now I change, I am going at 12 o'clock. You see well here, the lobe itself, the Cooper ligament connected to the fascia superficialis, and the fascia is connected to the reticula nutis, to the skin. The fascia is not connected to the skin directly, but indirectly to the reticula cutis. And then you have Cooper ligament here, one, another one. And in the Cooper ligament, have a look, you have this hypoechogenic structure. That means that the lobule go into the Cooper ligament. So I start here at 12 o'clock. Is it a normal pattern for you or something atypical? It's anechoic. So you have only fluid. So if you have only fluid, you have no cells. If you have no cells, you cannot have a tumor. That's a small ductal cyst. You have two types of cyst. You have lobular cyst, which are located there, and then it's a ductal cyst here. It's not easy for me, but I can show you other small cysts. And you have here the lobe, and we go to the extremity. Have a look. We follow the lobe at 12 o'clock. Have a look. How long is it? It should be, and I am going to go to the subclavicular, I need more gel, subclavicular area, where you have the ligament of Giraldez going to the clavicula directly. So you have to follow it because it goes very far. And here, at 2 o'clock, I follow the lobe itself, and I arrive nearby the axilla. That means some lobes are more than 14 or 15 centimeters in length, and you have to follow them to be sure to don't miss any small lesion here. So I make my examination around the nipple at the true beginning, and I jump from one lobe to the other. You are more familiar to the aspect now? So I jump from one lobe to the others, or I make examination from the nipple to the extremity, translation, two technique. I can make rotation internal after external rotation, and then here at 3 o'clock just linked to the Cooper ligament, which is here, you see, you have some hypoechoic modification. What that mean? You are in the lobe. So you know it's not the fatty tissue. The fatty tissue here is out of the lobe. Here you are in the lobe. You have a ductal line which is here. And here, that lobular modification. What should be this modification at the early stage? You have the multiplication of the line of cells. In a normal duct or lobule, you have only one or two line of cells. When you have the specific physiologic modification, which is called hyperplasia, you have multiplication of the line of cells. So the echogenicity change because you have more epithelial cells. And you said, oh, here you have some modification here of some lobules with hyperplasia. No hyperplasia of a duct, only from lobule. You know that you have the duct, and connect to the duct you have the lobules. And here that the small farm to produce milk. And in these lobules you have the group of acini I showed you yesterday with the video. So you see that you have some physiological change corresponding to hyperplasia. Hyperplasia is not suspicious, it's a modification, physiologic or under treatment. And we can ask Dana if she had some substitutive hormonal treatment. And so you have the explanation. If not, it's her physiology. But if that change, the evolution between the normal epithelial pattern, the hyperplasia, and after the in situ lesion, you have no modification of B mode, so that the limit of echography, you just select and you say, oh, this area, as you make follow-up later just to control. I am not, it's not suspicious for me. You see, you have other modification. Look, you have here the Cooper ligament, enlargement, and here the hyperplasia with a modification. Have a look. You see one lobule here, very small one. Another one here. Another one there. A biggest one here. And you have small here. You see them? So you have here the lobular epithelium. Now have a look to the eyes of Dana. She permanently look at the screen. Permanently. And if I say, oh, something wrong, immediately she look at me and she say, oh, what happened? But it's important because it's her exam and she will understand. And if something happens, she will be the first to know exactly what is my impression. Have you any remark for me here? Look here, his nipple is here. The nipple should be there for a better understanding. But you know, it's very easy for me. I just move the probe, nipple here, and the lobe goes this direction. And then I am unable to make a good examination in the other side. Nipple, areola, and the lobe here, and some ductal line. So we have some atypic here, atypia. What can we do? We are going to, Dana, to have a seat in front of me. Just here. Okay. Okay. And now we are going to perform the examination in a sitting position to try to enlarge the Cooper ligament and to make a better analysis in what is in, because due to the way you have some compression, and then we are going to try to make that in this position. It worked perfectly. Have a look here. All the things are separate and it's more obvious. And you see, no, it's not a tumor, it's a lobule with hyperplasia. You see the difference? That's the concept of the hyperplasia in the lobules is the most difficult analysis of the breast. Very difficult. But for her, it's very clear and evident. And if I want to make in this position the examination on the lobe at 6 o'clock, it's very easy because I am going to put the breast on the probe. Look at that, easy. You see the duct, different duct here? 1, 2, 3, 4. And you say, oh, the diameter of all these ducts are perfect, very small. And then I go to the extremity. And once again, you have some hyperplasia. Now I go at 5 o'clock. The lobe is here. At 4 o'clock. Now I change. I will make a conventional echography. You have one lobe here, another one here, and a third one here. How can you make a good analysis? You have not the axial ductal reference. You see, one lobe here, another one here, at 90 degrees section. I start again. One lobe, another one, and then I move the probe at 90 degrees, and immediately you see the analysis of the areola, the lobe, and the Cooper ligament. So just you make your examination, but if you have any doubt, you go to the lobar concept, and you are going to, here I am at 2 o'clock, and to follow the lobe to the axilla, and here you have the extremity of the lobe. This one will disappear, and this one. The first lobe who appear in the evolution of the breast are those located at the upper part. The last one at the inner inferior part. So the lobe here, inner, are smaller. I am going to show you. The biggest one are at 2 o'clock. And it's why I start on the left breast at 2 o'clock, so Dana will understand the anatomy of the lobe. Now if I go at I should say the lobe will be smaller. But due to Dana, it's wrong. She belonged to, how old are you? 53. For 20% of the patient, just around the menopause or after, you have an involution of the lobe. The lobe are going to decrease, disappear, but she will not have such. I don't know if she had hormonal treatment or physiological specific states, and that means that the lobe are going to stay like that in spite of the menopause or not. And so it's not a problem because you know exactly the lobe. I am here at 10 o'clock. The lobe are also big. You see the Cooper ligament here. And then the beginning of involution. But you can assert you are in a lobe. You see the ductal pattern. I move. You see the duct. Black one. Duct, ductal. I'm sorry, here. You see the duct, and you have another very small one in. You see the small one here? So you are sure that you have one part of the lobe, one part, and then you have the fatty involution, and this one is going to disappear the first. Cooper ligament, and we are here with a lot of hyperplasia, enlargement of the epithelium in the duct and in the lobules. Can you put your hand like that? I am going to go to the axilla. Maybe I need more gel. But you see, in a lying position or sitting position, it's very easy because we just try to look to the different lobes. They are completely independent. Some can be pathologic, the other normal, but we just follow the ductal axis, and it's why Dr. Tobul the first called that the ductal echography. And we go to the axilla, and we can make transverse scanning. You have a small, you see the lymph node here? Normal lymph node. If you want to find the lymph node, I don't know how to put the Doppler. You put the Doppler and you follow the vessels, and along the vessels you have the lymph nodes. And then I go back, I follow the extremity of the lobe, change again. Permanently, my left hand is dry, playing with the machine. My right hand is permanently full of gel because I take the probe. Just, you know, I put the probe with 2 fingers, but with other fingers, I make palpation by the same time automatically. So I have a double information, palpative and ultrasonic. You take the arrow and you are you able to describe what is on the screen or not? Yes or not? Okay, you try. Start with the yes. Yes. I help you. That, what is that? Fascia superficialis. And here, what is this part? Alors, Cooper ligament is here. You know, like a spine. But here, you have the upper part of the lobe. Then here, the lower part. Okay? You have fatty tissue here. And here, fatty tissue also. And here you have the muscle pectoralis. And what is that? Cooper ligament inferior linked to the fascia inferior. You have a miroir pattern. And here, what is that? A duct. And this group of hypoechogen structure is difficult, very difficult. Some group of lobules. Okay? I'm sorry, I will don't give you the probe to respect to Dana. It's not easy to perform the examination with blind technique because I cannot, but permanently I look at the breast, move the patient, try to, and ask. I want to make an interactive exam with Dana and the ultrasound scanning. And so at the end, she will understand. She say, oh, that's my breast. It's a normal one. He make a good job because I understand the pictures and I am safe. Can you translate her? No, okay, you understand. Okay, we tried with this one. It's okay. So you move. Oh, a little bit. Okay, you understand why? Because I need that the probe will be strict. Yes, I need that the probe will be strictly perpendicular and horizontal. If I want to scan here, I am in an oblique position. And I promise you that create artifact. You see some false abnormality, false tumor. So permanently, you take the probe with fingers, perpendicular and horizontal. And for the internal part, she is going to move after that. Usually, we start on the nipple. Start on the nipple. Have a look to the morphotype of the breast. Then the nipple, some duct, and we follow here. I am at 12 o'clock. And I follow the duct here, the ductal axis and the lobe. Okay? Now I go back and I go at 10 o'clock, just behind the nipple. And you have this, you see, Dana, this black structure. So, Doppler, please. Okay, thank you. Have you any vascularization interne? No. So, what is your opinion? Solid-like or liquid, but liquid some debris? It's not solid. If it's solid, you should have vascularization. So it's a dilatation behind the nipple, probably a ductal ectasia, and you have some debris in. No modification around. She knows that? Yeah. Okay. But it's important, you know that. And she is important that she look at the picture because he know exactly what happened in her breast. And after that, he say, okay, I know, but it's safe. I agree. Some dilatation of, I don't know why. I don't see any papillomas in. Maybe you have some papillomas, I don't know exactly. But we are not here to make a diagnosis. We are here to make an anatomic analysis and a technical procedure. Here, we follow the duct axis and we go to the axilla. Duct, one ductal axis, a second one, third one, all them converging vers the nipple. The extremity here, Cooper ligament, Cooper ligament, Cooper ligament. Inférieur, supérieur, fascia superficialis. Here also, you have some hypoechogenic modification. It's very difficult, but I tried to follow my arrow. Can you see here a ductule going up, another ductule going up, another going up. You can see them. Tac. Here, look at that, like a trees. That group of lobules with hyperplasia. Lobules, lobule, 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 lobule. You see the small ductule here? Are you able to follow my arrow and to see one ductule, one lobule, another one, branching, you know? So we are really under millimetric analysis because it's very small, but you understand what is the epithelial structure. And you see that the epithelial modifications are just at the crossing section between the Cooper ligaments and the ductal axis. You have no modification between, I don't know why, but here you have hyperplasia, hyperplasia, hyperplasia. But it's bilateral without any Doppler modification. So we can say to Dana, no problem, we can continue the examination. And then at 3 o'clock, at 6 o'clock, who corrects me? Nobody? The orientation of the nipple. Now, look at that. The nipple is here and the lobe going that. And you see well the ductal axis. Look at his wonderful Cooper ligament. Another one here. You have some ductal ectasia. Under 3 millimeters, it's physiological. Over 3 millimeters, it's a warning sign something happened. Physiologic or pathologic. Look how many small ducts you can detect. You see when you make little oblique movement? We are here at 6 o'clock. So due to the weight of the breast, the lobe is more triangular because it pressed like that. And you see perfectly one duct, another one, and you follow them toward the nipple. Going from the extremity, we follow them to the nipple. And you know the pathology of the breast is an epithelial pathology or ductal or lobular. You are convinced? So we try another model, another volunteer, another woman.
Cercellumeo. Realmente cercellumeo.
Thank you. Vous lui avez expliqué que
Okay. Dear online participants, we thank you a lot for your presence on these 2 days. Was a real pleasure for us to be together and to promote and to develop the uses of point of care ultrasonography in the ambulatory healthcare and then primary healthcare. We are in the finish of our program, and we invite you the next year to the same EUROSON POCUS School, which will be held in Vienna, but in the 2023. Thank you very much, and see you again next year.